It's been widely discussed, the number of transplants is increasing for both allogeneic and autologous transplants, and every day the number of the centers and the number of transplanters, even in our country, has been increasing, and people actually are adopting this therapy more and more, and this therapy is available to a large number of patients in the country, and we have the family-related donor transplants, we have unrelated transplants, and we have the haplotransplants happening all the times. And if you see this diagram, you will find the causes of death amongst the transplants, whether it is autologous or it is allogeneic. Even though the primary disease relapse remains the main cause, but the infection is actually number two, and a substantial number of cases come to the infection, and that is responsible for the mortality in the transplant. So infection is thus the major factor determining the outcome in the stem cell transplantation, and that factor one needs to keep in mind, because that can be a big hurdle in conduct of the transplant when the transplant program is being started in the center. As we know, why this problem occurs is because in the transplant there is a very prolonged phase of neutropenia starting from day 0 to day 30 till the time the engraftment takes place, and the key factors are because of the disruption of anatomical barriers, mucositis, devices, and impaired cellular and humoral immunity, functional hyposplenemia, and immunosuppressive therapy. If you see, and this is the period when infection comes up in various forms, whether in the early phase it's bacteria, fungi, or viruses. All these infections come and they cause damage to the recipient and may be responsible for the transplant patient recipient. This aspect actually can be certainly taken care of by the antibiotics, broad spectrum antibiotics, but what actually determines the occurrence of this complication is the place where we are conducting the transplant, and the place which we call as BMT, because the transplant itself is a unique procedure which is performed in a similarly unique area, the bone marrow transplant unit, which is a very unique, I would say, area which is very minimally equipped, and it has a pressurized positive air like a spaceship actually, and has got fitted highly efficient filters which provide a uniqueness to this unit. Not much of an upgrading has been done in mechanization of this unit from the time of its inception. It's a very simple place where the transplant is done. As you all must have seen, that there is no very intricate machinery kept in the transplant unit. We rather keep it as simple, as empty as possible to avoid too many cluttering of equipment, other things which can be a nidus of infection in the transplant unit. Do we really, in that case, need to concentrate so much on the transplant unit when it is actually not a very important aspect, because transplants are being done more of an outdoor procedures? We are not doing only myeloablative transplants. In fact, maybe the non-myeloablative protocols are being used more and more all over the country and over the world. And BMTs have been told that we can do the transplants in non-HEPA filter rooms also quite satisfactorily, especially in the economically poorer areas. So, do we need to place that much stress on the transplant unit, and do we need to see transplant unit during our training period? And I'm sure most of the residents hardly visit the transplant unit beyond that area where the patient is sitting, and I am not very sure that how many us are going during our training period into the mechanization of the AHU or the HEPA filter. And I will not be surprised if many of us as residents have not even seen HEPA filters during our training period. And I am also one of them actually, because when Dr. Maman is sitting here, who actually has taught me hematology and the transplant, during one of the rounds, after we finished a round in the transplant unit, I'm sure Dr. Maman wouldn't remember this, but he said, "Ajay, come, let's go and see the AHU." In Vellore those days, it was the old BMT unit. It was a multi-storied building, and the HEPA filter, compressor pump for the HEPA filter, they were on the top floor, I think crossing 2-3 stories through the steel stairs. And when we reached there, it was actually nothing very great to look at, all rusted iron, and the equipment was old. And actually he showed me how the pump works, how the gas goes, how's the air going downstairs. And I must admit, I was not very impressed with whole of the mechanization. I thought, because this factor didn't imbibe on me that how important is this, because I thought this is to be taken care of by electricians. They will handle it. Why should, we need to know. And I realized that problem when I came back to RR hospital in Delhi, and every second month or third month, the compressor pump would give away. The engineering department will not be very keen, and that would happen at 12 o'clock in the night on the weekends. So I think the training should include our introduction to the transplant unit. It is very important. It's an integral part of the transplant, and we should lay stress on our familiarization with the BMT unit. Basically, BMT is a clean room, what we know as clean room. And clean room is a room which provides the clean air. It separates the patient from the outside air, which is a polluted air, and it keeps him in a clean environment. The transplant recipient, as we know, is extremely immunocompromised, being under prolonged and deep neutropenia, which is a key factor for the occurrence of exogenous infections. The clean room technology actually has been defined by the 3 factors: the number of particles present in air, size of the particle, and concentration of the microorganisms in the room. Just going into the history, the BMT rooms were developed in the late 19th century. When after the after the First War, even when the radiation accidents had started occurring, the people's interest grew into the transplant units. HEPA filters were adopted in the BMT much later, and they started as efficient filters in early 20th century. In 1930, there was an attempt when the first HEPA filter was developed to protect the gas masks of Swiss Army in World War II. So a lot of contribution, I must say, from the armed forces. I wonder if you know that the first donor registry program was also started by the armed forces in US, and later on it was given to an agency, NMDP, as we know it today. Similar filters were used in Germany army hospitals to provide clean air inside the radiation treatment centers, and gradually the HEPA filter technology was adopted in hospital environment, not only in the transplant areas, but also in the operation theaters, the laboratories, etc. So if this is the transplant unit, it's very simple mechanism that you have the AHU which pushes the air under high pressure into the unit as shown by the filter inlet here. This is the patient's cot, and this is the outlet where the exhaust, where the air is going. But air does not go only through this because of the positive pressure inside this chamber and a negative gradient outside the chamber in the corridor and outside area. The air tends to go out. The air from the main room should go to the toilet also, where the gradient is maintained, and from there it further goes out. So that should be the flow of air in the positive pressure BMT unit, and so that the no air comes back to the patient once it is contaminated. It comes filtered air under high pressure, and then it goes out from all the vents in the BMT unit. Compared to that, let's have a look on the isolation room, where reverse occurs. Here the patient is under negative pressure. All the air comes from outside into the patient's room, and it also comes from the filters, and then it goes out. It never the air does not go into the environment because this is polluted air, because patient is carrying that aerosol infection, which we don't want to be spread to the general population. These filters actually have got multi-layered filters where they form a kind of web of the randomly arranged fibers which withhold the particles through interception, impaction, and diffusion as per the size. 0.1 micron or less are actually withheld because of the diffusion, and that adds to the efficiency of these filters. As we know, they are high efficiency particulate air filters. And this is the main component of the BMT unit. It has got 3 layers, as we just saw, pre-filter and 2 basic filters. They can filter up to 3 microns micrometer, which we use in the BMT providing 99.97% efficiency for removing the particles with 0.3 micrometer in diameter. The filters work on the principle of an exchange under the pressurized flow, as we just saw here. So these air flows are repeated periodically. So this is how a HEPA filter would look these days, and they actually are put into, I have not taken a picture of the inside of the BMT, but you must have seen that they are put into, in many units they are put into the roof, into the wall, but the best thing should be that they should come onto the patient, and from the air should go in a laminated manner all over outside. The 0.3 micron filter, and in the BMT views about ISO class 5 to 7 will actually hold these many particles still inside this unit, which is adequately acceptable for the BMT. So a positive and negative pressure rooms, the comparison would be that pressure relation to the adjacent area is positive in the BMT, while in the isolation it was negative. The air exchanges of outdoor air per hour will be 2, and minimal total air exchanges per hour will be 12, and so there will be 24 and 24 hours. And all air exhausted directly to the outdoors in a case of isolation chamber, while it will not be allowed to happen in the BMT unit, and no air circulation, recirculation within the room units is allowed, and the temperature, optimal temperature, ambient temperature is maintained, and this positive pressure unit is used, what we know, in the BMT, while the isolation with negative pressure is used in the isolation room. Both rooms are equipped to provide filtration of 0.3 microns with an efficiency of 99.7%. After this air hygiene, we need to think about the water hygiene, because it may be as much or even much more hazardous than the air pollution. The water coming from healthcare centers, what the healthcare department is supposed to supply, should meet the drinking water requirements. But that does not perhaps happen in most of the cities in our country. That's why the water supply, the pipe water is not used for the portable purposes. We always use some filtered water. Even the clean water, which is supposed to be cleanly supplied in best of the places, it's not optimal to be used by these BMT patients, because microbial infection agents that are safe for the healthy persons, but they are not so for the BMT patients. So because the water distribution system, it does get contaminated by the filamentous fungi, gram-negative, non-fermenting bacteria, which can be the source of infection in these patients, and humidity further promotes the colonization of bacteria and fungi, and these factors would contaminate the water, which is, even though it has been processed, cleaned and filtered, but by the time it would reach the tap, it would all be contaminated. And the decontamination results in the BMT must always be verified by the growth media, which should be periodically performed. To just give an example that this can be really a problem, we have these kind of reports coming up in the literature where there have been the outbreak of Legionella pneumophilia serogroup 3 in a transplant unit, and it was identified, and the good thing is that it was identified in time. Within a span of 6 months, there were a number of patients, one after another, who developed Legionella, and when it was investigated, it was found the source was again the pipe system of the BMT unit. Similarly, the viral infections can occur any time, and there may be other presentations of BMT unit related complications in the BMT recipient because of infection. So if we can maintain the water and air supply of the BMT in the best of manner, we can avoid these complications because of infections. Because for a good outcome BMT program, the quality of BMT should be perfect, it should be standardized, and whatever has been standardized, whatever has been done, should be validated by the accepted norm of accreditation. Before we go to the norms and their accreditation, let us see the other components of the transplant units. I'll be going briefly into all these aspects, because each of these are huge topics to be discussed separately, and they may not be of, actually all of them may not be of our interest. So I'll just touch upon which ones are the important one. Structure, actually it's an engineering work. It should be done done by the engineering department who's been experienced in the OT constructions, transplant unit constructions. The transplant team should be the part of the construction team, and you need to be involved with the construction of the BMT unit. The designing should be also scrutinized because that should meet the criteria that we are developing the BMT unit for, how much we need it, and what kind of transplants we are planning to go for that. Provisions of AHU, HEPA, and laminar, HEPA filters and laminar flow should be understood by the transplant team, and then it should be guided to the engineering department. We should understand the plan of the corridors, anteroom, main unit room, washroom. One important thing which we need to keep in mind is that while constructing the mechanics of the building, we should keep in mind that as much as possible the areas, the surfaces must be smooth, the doors must be automatic. They should not, the minimal touch should be required to open and close them. The design should be patient friendly. Flooring should be smooth so that the colonization does not take place, and it should be washable. And same should apply to the ceiling. And in many units, the ceiling is removable. That aspect also should be kept in mind because that can give rise to dust particles coming inside, and sometimes even the rats have been reported in the transplant units. So all these facts have to be kept in mind. Water, air supply we have just discussed. The sterilization. The transplant unit as far as possible should have a dedicated CSSD facility. Autoclaving of all the equipment and personal items of the patient should be ensured. ETO for the non-autoclaving objects, the personal items of the patient. Actually, the dictum is that nothing without being autoclaved or without being subjected to ETO should be allowed to go into the unit. This aspect has to be kept in mind, and we should be very careful in training our team, training our nursing staff to ensure this. Each room should have additional UV port for taking the day-to-day items inside the transplant room. We should have a planned schedule for the linen sterilization of the staff linen, the patient's clothes, and the attendant's clothes also. The nursing station is an important area. For a transplant unit, it should be specially designed because nurses are going to monitor these cases almost 24 hours. The doctors will not be there all the times. We should have a separate changing room, come retiring room for the nursing staff. The store should have the area for the stationery, disposable, and pharmacy storage. This area should be accessible to the nurses because it has to be outside the main transplant room, so that should be planned. There should be emergency resuscitation equipment, which we often do not have in the transplant units, but we should have this kind of equipment, and we should actually also train the staff periodically. All the protocols which are written and instructions should be accessible to the nursing area because they are the ones who are going to use it often. The doctor area, the duty room, rest room should be thought about and be provided, library and IT facilities. BMT should have a procedure room because depending on the hospital practices, there may not be any area where we can do the central line dressing. So that should be, especially when they sometime come post-transplant or just after the transplant when they come for the dressing and various other procedures like cyclosporin level assay and medication. Medication outside the main area of the BMT also should be thought about and should be provided because during conditioning, when you give GCSF and other things, when patient is not admitted, should be done as well as possible in a clean environment.
Sir, only 2 minutes left.
Okay. So similarly, we have the other areas. Hence, for a good outcome BMT program, the quality of the BMT unit should be perfect, standardized, and should be validated by the accepted norm. Coming to that, how to ensure the quality control. So we have to see check the filters as per the manufacturer's recommendation. We should replace them often. The filter efficiency should be checked frequently, and there should be directed flow, the unidirectional flow from outside to inside, and positive pressure differential should be maintained, and it should not be so much that it becomes uncomfortable for the patient. The BMT room should be built in airtight to prevent infiltration of the polluted air. Constant pressuring should be monitored, should have self-closing doors, unidirectional pressure gradient, and air condition should not be installed. Many BMT units, when we go and we find there are air conditions installed, that actually should be avoided. Is maintaining air quality in the BMT high? That actually is a question which has been often asked, but we know that BMT needs to have a standardized protocol to maintain the HEPA filtration. So we should have protocol to maintain our HEPA filters. We should replace them periodically depending upon the requirement as per the manufacturer's literature. When we talk about standardization, there is a step towards it. It's important to lay certain standards. So that's why now we have the JC model of the standardization, which is Joint Accreditation Committee of ISCT and EBMT. ISCT is International Society of Cellular Therapy. So they, along with the foundation of the accreditation of cellular therapy, have come out and have brought out the JC FACT model, and which provides the guidelines for the standardization of the BMT. I'm not going to the details, but just to mention that it is now it's a recognized body which actually identifies the centers with which meet the standardization and certifies them, and it is good to involve in their accreditation. The accreditation will make the planning. There is an objection to it that does it make the planning difficult, or it increases the red tapeism and it does not allow the new centers to develop. But these are actually fears which should not dissuade us to be the part of the accreditation program, and we certainly should try to meet the criteria which the JC protocol has outlined in their website. They are available free to all centers whosoever wants to access them. So BMT is an ever progressive field. It is the unit's main step, though it has been most neglected area, and good state-of-art BMT unit is the key to the successful transplant program. Well-equipped BMT unit is an essential component of the transplant program, and the unit demands would keep changing with the changing protocols of pre-transplant changes, but most important is the standardization and accreditation of the whole process, and we should do our best to make a unit as efficient as it is required on our day-to-day development in the transplant program. With that, I'll conclude. Thank you very much.